we need to know some things that we don't know. And in the case of epilepsy surgery, there is this very special group of patients that we actually can cure. And those are people that have epilepsy, and they have epilepsy that seems to come from one area. And with the right testing and with the right conditions being met, then they might actually be eligible for this surgery. In that group of people that could be eligible for surgery, some of them do go for surgery, and a group of those people actually become completely seizure-free. And even in that group, some of them stop going on medicine. So even if you're not completely cured, you can have a seizure-free life after surgery. And even if you're not seizure-free, you can have many less seizures. So there's all sorts of good reasons to think about wanting to do surgery in the right people. But who's the right people? We don't know. We thought we knew for the last 20 years or plus, or even longer. And we have all these beautiful papers and research groups and cohorts and retrospective analysis, and everything that we've ever figured out is just incomplete. We always make these predictions about people that should be good candidates, and really they fail the surgery and they keep on having seizures. So how do we do it right is a problem. And years ago, I did a study with the NIH trying to look at retrospectively 151 patients, and we weren't able to make excellent predictions despite the fact that we had PET scans and MRI scans and video EEG, routine EEG, and all kinds of neuropsychological evaluations, all kinds of great stuff to know about the patients. It wasn't enough. Larger studies than mine have looked at 800 patients, 1,000 patients, and they've done all these fancy multivariable analysis and even some AI tools. It's not enough. We don't have the answer yet. And so, the dream of AI is you just give it enough data, it'll just answer your problems. I love that, and I hope that that is true. There are some problems that AI has never been able to answer and may never be able to answer. We don't know. But this is a problem that we need answers to. If we can do 5% better, then we will help 5% more people. If we can do 10% better, we will help, and so on. So we must push forward, and we need to do better. And the paper that you referred to is me basically sharing my experience and in terms of what I actually tried to do, but then also in the papers that I've been reviewing and my understanding of AI and what are the barriers that we need to overcome in order to get better at predicting these patients. We need to be able to help people better. One of the really silly things that's kind of counterintuitive is we need to know who to say no to. Don't do surgery, please, because you're going to fail. I don't know who those patients are. It's hard to figure out who those people are. And there's some very early hints that there are some studies that might be able to identify those people. If we just identify those, then our surgery will be more accurate. Our patients will be happier, and we'll do more appropriate surgeries and less inappropriate surgeries. Some of the many hurdles. So one of the questions that people think about is, is my AI really good at predicting surgical outcomes? And the general AI paper is usually framed like this. There's this big problem. AI is going to solve it. We got some data. We poured some AI all over it and a little bit of pepper. And then we took it out and look, the answer is that the AI is pretty accurate. And that's like the end of the paper. And, therefore someday, good things will happen. And that general recipe is not appropriate for surgical outcome studies. And the reason that I say that is what I was just talking about, this idea that there are some patients that we should never send them to surgery. So you don't want an AI to be accurate. You want an AI to be accurate in a particular way. You want to know who to walk away from, because most patients that have drug-resistant epilepsy, that have focal epilepsy, might be good candidates for surgery, and might means there's a certain chance. So all of those people, your hopeful doctors and your hopeful epilepsy centers are going to say, let's give it a try. We will have to do something. We've tried 20 drugs on you. You're still having seizures. Seizures are life-threatening. We hate that. So come on in. We'll do something. And what you don't want is an AI that is good at saying this might work, because we already say that without the AI. Instead, what we need is the AI to say, this patient looks highly similar to all the other patients that fail. Those are the people that we say, look, I'm a very hopeful doctor. I'm a very hopeful surgical center, whatever. We love bringing people in, but you you're different, and we should not be focusing on doing a surgery because you're not going to like what happens with us. And so one of the pitfalls that I discussed in that paper is thinking in that different way, that accuracy in general is not the question. Accuracy and negative predictive value is very, very critical. A second pitfall that we talked about is this idea of having an external validation. And this is sort of obvious AI stuff. But people that just, again, they're pouring on AI and pouring on some pepper. It's really nice to get a publication and to try out AI. Hey, maybe the AI will be better and all that. But we need something that's not just having AI, but we need something that's AI that's generalizable. And in order to do that, you try it out. You come up with some idea that seems like it's working, but what if I try it in a different group? And if I try it in a different group and it doesn't work anymore, then it was flashy and it was neat, but it's not relevant for real people yet. So, and there's more, I recommend people that are interested in this topic to go take a look at our paper. It's just a set of suggestions and mainly from other people, but some of them are just my opinion, having reviewed a lot of this stuff, having thought deeply about it, and having also a pretty strong background in AI.